Hi, I'm Mihaela Stefan. I'm a hospitalist in Baystate Medical Center in Springfield, Massachusetts. And I'm also a researcher and one of the directors of the Division of Healthcare Quality. The focus of my work is to develop and implement strategies to improve the outcomes of patients with respiratory failure.
Hi, I'm Jay Steingrub. I'm a critical care physician, of NIH-funded researcher and professor of medicine and surgery at UMass Medical School-Baystate. And my interest in the last couple of years has been the application of evidence-based medicine with clinical decision-making as it's related to NIV use to promote better patient care.
We want to invite you to join a learning collaborative which is supported by the National Institute of Health to improve the outcomes of patients hospitalized with COPD. And we will achieve this objective by supporting your institution to implement strategies to increase the use of evidence-based care for COPD patients and state-of-the-art techniques in ventilation management. At the heart of this project is increasing the uptake of appropriate use of non-invasive ventilation. And this is based on prior research which showed that hospitals with higher rates of initial non-invasive ventilation had better outcome, including decreased in mortality, in length of stay, and hospital costs.
Now, regarding non-invasive ventilation, basically it's a tool, whether it's BiPAP or CPAP, it's a tool that will support a patient's lung function while waiting for other treatments to work. What do we know about NIV use? Over the past 2 decades, NIV use has increased significantly without strong supporting evidence for its use in different types of acute respiratory failure. Accordingly, appropriate patient selection and monitoring is warranted to maximize favorable patient outcomes associated with NIV use. As we approach evidence-based medicine and NIV use, it requires an integration of the clinical expertise and the best available clinical evidence. Expanding clinical practice, unfortunately, does not keep pace with available clinical evidence. There's a huge gap between clinical practice and evidence-based research. Hence, before making a decision, it's important to evaluate the evidence. Based on the evidence via multiple guidelines and supported by several randomized controlled trials, that the cornerstone of therapy for acute exacerbation of COPD and acute heart failure is the use of NIV. When it's applied early, it produces better patient outcomes. And as Dr. Stefan said previously, NIV use is associated with low intubation rates, lower length of stays in the hospital, lower mortality, lower hospital charges, and lower 30-day readmission rates. So NIV is safe and cheap to use.
So I want to present to you the features of these learning collaboratives. We develop guidelines and algorithms for the use of NIV and for COPD management that we'll share with you. We'll have monthly webinars with subjects including various COPD evidence-based care. We develop educational modules specific for the respiratory therapist, for nurses and physicians with continuing educational credits. And for the entire duration of the study, which is 18 months, there will be support from COPD and NIV experts. So why join? Of course, there is this potential to improve the outcomes of COPD patients, and I want to assure you that will be a low burden for your institution. You'll not need to hire additional personnel, collect data, or prepare documents for the IRB. So we hope that you will take this opportunity to join these learning collaboratives, and to join, follow the link, which is in this slide, or please contact me, mihaela.stefan@baystatehealth.org. Thank you very much.
Thank you.